Hello and welcome to my audio medical basics, where I read medical books to your ears when your hands are too busy to hold a book. If you like, please don't forget to like, share, and subscribe. Let's continue reading from my case files collection, and today we'll be reading a case from the case files surgery. And I left surgery for last because I think surgery is the most changing of the medical professions. I was reading with a new surgery or technique popping up like every day or even every second. So I'll remind you again that these videos I'm making, these audiobooks, are for revisions, are for exams, are for studying and refreshing information, and for case preparation. But as I mentioned before, they are not for direct application on patients. And as mentioned in the book itself, the notice at the beginning, which I showed earlier, the disclaimer, that I will
pause. If you can pause, this disclaimer here. I cannot show back enough. It's very important to remember.
which disclaims any responsibility because the book is up to date, but medicine is ever changing, as we mentioned before. So today we will do a case of gastroesophageal reflux disease. Gastroesophageal reflux disease, abbreviated as GERD or GERD. Summary. A 48-year-old man complains of a 4-month history of daily burning epigastric pain. It is worse after eating and lying down, and minimally improved with the use of proton pump inhibitors, abbreviated as PPI. So PPI, proton pump inhibitors, in case I forgot. He also has symptoms of reactive airway disease and hoarseness, this patient. Most likely diagnosis is gastroesophageal reflux associated with silent aspiration and pharyngitis. So what is the most likely diagnosis in this patient? Gastroesophageal reflux associated with silent aspiration and pharyngitis. What are the mechanisms contributing to this disease process? So the mechanisms are diminished lower esophageal sphincter function. The LES function is diminished. LES is lower esophageal sphincter. Impaired esophageal clearance, excess gastric acidity, diminished gastric emptying, and abnormal esophageal barriers to acid exposure. So what are the complications associated with the disease process? They are peptic stricture, Barrett esophagus, and extraesophageal complications. The objectives of this case is to learn the physiologic mechanisms that prevent the pathologic processes that lead to gastroesophageal reflux disease. Also, to learn a rational diagnostic and therapeutic approach to suspected case of gastroesophageal reflux disease. Considerations. This patient's history of substernal chest pain, the patient mentioned in the long case, this patient's history of substernal chest pain associated with meals is typical of gastroesophageal reflux disease. Hoarseness and wheezing are atypical symptoms that may be related to pharyngeal reflux with silent aspiration. Evaluation by an otolaryngologist may be needed to rule out oropharyngeal and vocal cord pathology. One of the most alarming features in the history is the lack of response to the proton pump inhibitors, which produces symptoms relief in more than 95% of treated patients. So more than 95% of treated patients respond to PPI, but in this patient there is lack of response. So therefore it is extremely important to confirm the diagnosis of gastroesophageal reflux disease and to rule out other pathology. Endoscopy should be performed. At a 24-hour pH monitoring while the patient is off medication is appropriate to correlate the symptoms with episodes of reflux and quantify the severity of the reflux. Pharyngeal pH monitoring, which measures proximal esophageal acid exposure, may help support a diagnosis of silent aspiration. Although H2 blockers can provide symptomatic relief for mild reflux, PPIs, proton pump inhibitors, are far more effective for the relief of gastroesophageal reflux symptoms. However, patients with extraesophageal symptoms and pharyngeal reflux may be less responsive to medical treatment. Surgical therapy is an alternative to medical therapy and may be considered if the patient does not respond to medical therapy, cannot tolerate the medications, or prefers surgical intervention. Okay, so the approach. Let's start with the definitions. Gastroesophageal reflux disease. Symptoms of heartburn caused by acid regurgitation from the stomach into the distal esophagus. So, gastroesophageal reflux disease are symptoms of heartburn caused by acid regurgitation from the stomach into the distal esophagus. Barrett esophagus is the replacement of the normal squamous epithelium of the distal esophagus with columnar epithelium with intestinal metaplasia, which places the patient at risk for esophageal adenocarcinoma. So what is Barrett's esophagus? Barrett esophagus is a replacement of the normal squamous epithelium of the distal esophagus with columnar epithelium with intestinal metaplasia, which is risky for adenocarcinoma. Manometry and pH monitoring are is a combined procedure in which a small electronic pressure transducer is swallowed by the patient to be positioned in the vicinity of the lower esophageal sphincter. Clinical approach. Occasional gastroesophageal reflux or heartburn occurs in approximately 20% to 40% of the adult population. Not all patients with typical GERD-like symptoms have reflux, around 60%. Therefore, it is important to look for alternative causes of symptoms in patients with atypical symptoms or inappropriate response to proton pump inhibitors. So not all patients with typical gastroesophageal reflux disease-like symptoms have reflux. Therefore, it is important to look for alternative causes of symptoms in patients with atypical symptoms or inappropriate response to proton pump inhibitors. Patients with long-standing gastroesophageal reflux disease may develop complications such as peptic strictures, Barrett esophagus, and extraesophageal complications. Barrett's esophagus is associated with an increased risk for esophageal adenocarcinoma. Extraesophageal complications postulated to be caused by pharyngeal reflux and silent aspiration include extraesophageal complications postulated to be caused by pharyngeal reflux and silent aspiration include laryngitis, reactive airway disease, recurrent pneumonia, and pulmonary fibrosis. Okay, this is all for part 1. And in part 2, we'll continue with the pathophysiology,
of gastroesophageal reflux disease.